Hello, everybody. After a long pause, I'm again back with an interesting topic for my channel, which is catastrophic autoimmune hemolytic anemia. Though in my last recording, I mentioned that we'll try to be more regular in my channel in terms of uploading videos, but somehow I'm not able to manage time because of a lot of things. But this topic I find interesting, and it I presented in a critical care conference in Kolkata, and I thought to record it and upload it for my friends. So in next 15 to 20 minutes or so, we'll go through a topic called catastrophic autoimmune hemolytic anemia. Though the title says catastrophic, but it's more of a subacute onset of disease, and mostly they present with an anemia to ICU, and you need to do the appropriate workup to identify the cause. It can be a catastrophic problem in certain patients, specifically if it is associated with antiphospholipid antibody syndrome. So this is a group of disorders characterized by autoantibodies that binds to red blood cell surface antigens, leading to premature destruction. This can happen in two ways. It can be extravascular hemolysis, primarily by the spleen, or intravascular hemolysis, which is complement mediated. In terms of epidemiology, it's a rare disorder. Incidence is up to 3 cases per 1 lakh person annually. Prevalence rate is around 17 per 1 lakh population. It can affect all ages, but peaks in the middle age and the older population. Most commonly, it is warm autoimmune hemolytic anemia. We'll see what is a warm autoimmune hemolytic anemia or warm antibodies, which constitutes approximately 70 to 80% of all cases. Cold agglutinin disease contributes 15 to 25% of cases, and there is a mixed variety along with paroxysmal cholecyria, hemoglobinuria, which is around 5 to 10%. In terms of the demographic distribution, I already mentioned this is a higher incidence in the middle age and the elderly population, but still it shows a bimodal distribution. In the adults, mostly it is a warm antibody, and the cold and the paroxysmal cold hemoglobinuria is more common in the children. The sex in the females are more predominant in terms of the disease by nearly 2 times compared to male. And the paroxysmal cold hemoglobinuria usually happen in children after a viral illness. This can be primary or secondary. Primary is idiopathic, which is around 40 to 50% of cases, and the secondary, which is 50 to 60%, is associated with another underlying disorder. It can be lymphoproliferative disorder like CLL or lymphoma. It can be autoimmune disease like SLE or rheumatoid arthritis, or it can be after certain infections, medications, and certain malignancies. In terms of morbidity and mortality, overall mortality rate can be 8 to 9 to 11%. It is higher among elderly. Biggest morbidity is thromboembolic complication, which can be as high as 30%. And this subgroup of patients usually require 40 to 60% of those patients require transfusion, and nearly 20 to 30% of those patients eventually develop a refractory disease requiring multiple lines of therapy. If I try to classify this group of disease, the most important and most common is warm autoimmune hemolytic anemia. The most common type among this, which is nearly constitutes 70 to 80% of all cases, incidence 1 to 3 per 1 lakh annually. It is characterized by autoantibodies, which is predominantly IgG type, that optimally binds with RBC at 37 degrees centigrade temperature, that is the body temperature. In that situation, we should try to identify the underlying etiology, underlying pathology that can lead to this disease. And if you look at the pathophysiology, IgG autoantibodies binds with RBC membrane protein, most commonly the Rh antigens, and it leads to primarily extravascular hemolysis by phagocytosis of the macrophages of the spleen. Except that FCY receptors on splenic macrophages recognize the FC portion of the RBC bound with IgG. There may be a complement activation, but it is not essential and rarely leads to an intravascular hemolysis. If you look at the key clinical features, it's mostly presented with progressive fatigue, jaundice, sometimes mild splenomegaly. Hemoglobin is typically from 7 to 10 gram per gel at presentation. In severe cases, it can be less than 7. There is increased risk of venous thromboembolism, as I already mentioned. The laboratory shows direct agglutinin test positive for IgG and very rarely for complement 3 also. Peripheral smear shows cystocytes, phagocytes, and no cold agglutination or acrocyanosis is present in this group. And the thermal amplitude testing show a maximum binding of these antibodies at 37 degrees. That's why it's a warm autoimmune hemolytic anemia. In terms of the management, this first line is glucocorticoid with or without rituximab, which is an anti-CD20 antibody. Initial response occurs in 70 to 80% of cases, and it has been shown that DAT strength may correlate with the hemolysis severity and the treatment response. Next is cold agglutinin disease. Here, there is a IgM autoantibody or cold agglutinin that target RBC antigens, and typically that is I antigen. Here, the thermal amplitude shows a binding of at a colder temperature, less than 30, causing agglutination in the acral areas. There can be it can activate a classical complement pathway, that is C1q, followed by C4 and C2 and C3 fragment on RBC. Primarily, it's an extravascular hemolysis by the liver macrophage, with some intravascular hemolysis. These are usually monoclonal antibody, mostly kappa light chain, and it is associated with low-grade lymphoproliferative disorders according to the WHO classification. In terms of the clinical feature, I already mentioned, this is primarily the disease of the elderly, mean age is 60. They mainly present with a chronic anemia with a hemoglobin around 9, 9.5, with markers of hemolysis. Along with that, there are cold-induced worsening of the symptoms in up to 90% of the patients. They present with an acrocyanosis, which is purple discoloration of fingers, toes, ears, and nose. There can be livido reticularis, Raynaud's phenomena, and there may be a worsening discomfort with cold beverage and food. So, to the diagnostic criteria are evidence of hemolysis, that is high LDH, high bilirubin, low haptoglobulin, along with positive DAT test for complement 3 only. There can be very weak IgG positivity in up to 25% cases, but mainly it's a complement 3 associated disease. The cold agglutinin titer should be more than 64 at 45 to 40 degree temperature, but to be clinically significant, or in clinically significant cases, the titer is more than 512. There's another variety which is called mixed autoimmune hemolytic anemia, where there's a combination of both warm and cold antibodies present. So you can see both IgG and complement 3 detected in patients' RBC. There can be multiple mechanisms of hemolysis depending on the predominance. There will be extravascular by IgG mediated and complement mediated intravascular hemolysis. May present a more severe form of disease because of complex immunopathology. In terms of diagnostic test, direct antiglobulin test, positive for both IgG and CD complement C3, may require additional testing like cold agglutinin titer and thermal amplitude. It needs to be differentiated with warm autoimmune hemolytic anemia with complement fixation test because the treatment will be a little different, and careful assessment needs to exclude underlying disorders like lymphoma, autoimmune disease, which I already mentioned. Most of the time, there is an underlying pathology. Now, this has some clinical significance because it usually a severe onset disease with poor response to therapy. They usually do poor compared to the conventional warm variety. There's a higher relapse and refractory rate compared to the other types of autoimmune hemolytic anemia. International consensus recommendation shows early aggressive therapy with a corticosteroid, maybe along with rituximab, and splenomegaly is generally ineffective and is not recommended. Another variety is paroxysmal cold hemoglobinuria, already mentioned. This is a rare form of autoimmune hemolytic anemia caused by IgG autoantibody that fix complement in the cold. Okay, so there's something different in terms of the pathophysiology. Historically, it is associated with syphilis. Now, most common cause is seen after a viral infection in children. It is characterized by episodes of acute intravascular hemolysis after a cold exposure. And the mechanism of this hemolysis is called Donut Landsteiner mechanism. Sorry, because there is a biphasic hemolysin. Here, the IgG autoantibody bind to P antigen on RBC at cold temperature, that is less than 20 degree. After this autoantibody fix complements while bound on the RBC in the cold phase. Now, upon rewarming to 37 degree, this antibody is dissociate, but the complement remains attached. And there is a complement activation leading to intravascular hemolysis and hemoglobin. So what are the clinical features? There is a dark red bound urine. There is hemoglobinuria. Begins minutes to hours after the cold exposure. The acute symptoms can be back and leg pain, abdominal cramping, fever, chills, and malaise. Laboratory findings include positive DAT with complement 3, but negative for IgG, as I mentioned this. And there's a positive Donath Landsteiner test. Most of those diseases, the course of the disease are self-limiting in children, can be severe in adults, and very rarely can cause an acute renal failure. There is another group where the conventional DAT, direct agglutinin test, is negative. And so as a result, but there is evidence of clinical and laboratory evidence of hemolysis. So this is called DAT negative. It's present up to 10% of cases, but it's mostly misdiagnosed as non-immune hemolytic anemia without detailed investigation. So if you're suspecting a DAT for a hemolytic anemia, autoimmune hemolytic anemia, then to be more detailed investigation in this group. Why these tests are negative? Why that is negative? Because the standard DAT may miss low level of RBC bound antibody, that is below the detection threshold. Autoantibodies may be IgA class, so not detected by the conventional DAT. Low affinity antibodies may detach during washing procedure, and the RBC sensitization below the threshold of conventional DAT detection. So more sensitive methods for detection of RBC bound antibodies need to be done, like flow cytometry, which can detect as few as 30 to 40 molecule of IgG per RBC, enzyme-linked antiglobulin test, column agglutination with polybrin or low ionic strength solution, or special anti-IgA reagent to detect IgA-mediated cause. Management strategy generally managed like a warm autoimmune hemolytic anemia, like corticosteroid to begin with. Similar response rate like immunosuppressive therapies, and other, if you are not very sure, even then you can consider to give a trial of corticosteroid. And you can consider to refer them to specialized center for advanced testing methods if you are not sure about the diagnosis. Autoimmune hemolytic anemia can happen because of drug also. Here it is triggered by medications exposure, which is now they're serologically indistinguishable from a worm variety. So to take a detailed history of the associated drugs. It can be drug-dependent mechanism where the drugs act as hapten or form immune complex with RBC protein, or it can be a drug-independent mechanism where the drug induces autoantibody production via immune dysregulation, and then the cascade begins. Most common drugs can be antibiotics like cephalosporin, penicillin, and rifampicin, anti-inflammatory like NSAIDs, for example, diclofenac, anti-neoplastic drugs like fludarabine or cladribine, other drugs like methyl-dopa, L-dopa, tacrolimus, and interferon alpha. So what are the management strategies? First step, identify and discontinue the offending drug. Hemolysis typically resolves within days to weeks after the drug discontinuation, but for severe cases with ongoing hemolysis, standard treatment like the worm variety need to be done, like a glucocorticoid. And important point is that drug rechallenge should be avoided, should not be considered. And that diagnosis is confirmed when hemolysis is resolved after the drug withdrawal. Sometimes hemolysis persists, as I mentioned, making life difficult. So consider the drug history of all newly cases of autoimmune hemolytic anemia. And if you have a pharmacovigilance system, please inform them or keep them in loop for workup of the drug. There's another interesting etiology of a type of autoimmune hemolytic anemia, which is called passenger lymphocyte syndrome. It happens in post-transplant patients where the donor B lymphocyte produces autoantibody against recipient red cell antigens. It can happen after solid organ transplants like liver, kidney, or heart lung, or it can happen in hemopoietic stem cell transplant also. It typically involves donor-derived antibodies against major AB antigen or minor blood group antigen of the recipient. In terms of clinical presentation, symptoms typically appear 7 to 14 days post-transplant and lasting up to 3 weeks. Features of hemolytic anemia will be there. We already discussed. Severity ranges from mild compensated hemolysis to severe transfusion-dependent anemia. Most common in group O donors to non-O recipients. Through any blood group incompatibility, though any blood group incompatibility can trigger passenger lymphocyte syndrome. How to diagnose transfusion with a donor compatible blood such as group O RBC for avian compatible cases, modification of immunosuppressive regimen to suppress the donor lymphocyte activity. Some patients may need IVIG and plasmapheresis for severe hemolysis. This is mostly self-limiting, resolved within 4 to 6 weeks of donor lymphocytes are eliminated or become tolerant with the patient's body. If you look at the pathophysiology, I've already discussed a bit. It's antibody-mediated destruction. It's happened because the antibodies are targeted against the red blood cell antigens. Two main pathology, IgG-mediated up to 80% and IgM 20 to 30%. In IgG-mediated disease of warm variety, thermal activity is at 37 degrees or body temperature. Primary destruction is spleen, that is extravascular. Complement activation is limited and mostly that is positive for IgG. Where in IgM mediated, it's mostly happen in cold temperature, less than 30, sometimes less than 20. Most site is extravascular site is liver, or there can be an intravascular hemolysis because of robust activation of complements. And that is positive mostly for complement 3 and sometimes for IgG. And depending on that, again, they can be differentiated into extravascular and intravascular hemolysis. I've already discussed. Clinical implications, there can be risk of acute renal injury because of intravascular hemolysis and hemoglobinuria. And depending on the mechanism, CD24 antibody production or complement inhibitors can be used in severe cases. In mixed variety cases, both mechanisms are there, we need both type of therapy. That is both to suppress your IgG production and also suppress complement activation. Clinical manifestations, general symptoms or signs are common, like manifestation of anemia. We will present with the fatigue, weakness, exercise intolerance, pallor, maybe dyspnea on exertion, palpitation, and dizziness in moderate to severe anemia. Severity varies. Mostly the hemoglobin is around 7 to 10 gram per dl, but in some severe cases it can be less than 7 or even less than 6. They usually present with a jaundice of skin and sclera because of increased bilirubin production, splenomegaly because that's the site for warm variety. Now, 40% case you can get a splenomegaly, which is mild to moderate. And in case of cold variety, you can get ectocirrhosis with blue coloration of the extremity. There will be associated hemoglobinuria and signs of intravascular hemolysis. So you'll get hemoglobinuria presented with a dark brown urine. More common is paroxysmal cold hemoglobinuria and severe cold variety. Acute onset fever and chill because of hemolytic crisis. Abdominal or back pain in severe hemolytic crisis, and hypotension, tachycardia, and acute severe hemolysis. And they may present with an emergency cases. In terms of specific manifestation, in cold agglutinin disease, as I already discussed, is mostly acrocyanosis, that is blue and purple discoloration of the extremities, fingertips, toe, ear, nose. Raynaud's phenomena with sharply demarcated color changes, livid reticularis, blanchable, patchy vascular pattern, pain and discomfort and swallowing the cold food, and cutaneous ulceration and necrosis in severe cases if things doesn't get resolved with appropriate treatment. In paroxysmal cold hemoglobinuria, though it looks little similar in terms of presentation, but pathophysiology is very different. So also the treatment and also the diagnosis. So this subgroup present with dark red or brown urine because of hemoglobinuria, which happens minutes to hour later the cold exposure. Back or leg pain or abdominal cramping during acute attacks along with fever and chill may be present. Mostly it's a self-limiting disease in children after a viral infection. Acute kidney is a potential complication or morbidity. Key distinguishing feature is the biphasic hemolysis in paroxysmal cold hemoglobinuria. That is, Donat-Landsteiner antibody binds with cold and temperature, but cause complement mediated lysis in the after rewarming up to the body temperature. In terms of complications, two main morbidity, venous thromboembolism and acute kidney injury. Up to 30% venous thromboembolism can happen, higher risk in severe hemolysis and active disease. There is an increased risk of DVT, pulmonary embolism, and cerebral thrombosis. So, VT prophylaxis is recommended in all hospitalized patients and those with severe hemolysis. In acute kidney injury can occur in severe intravascular hemolysis, especially paroxysmal cold hemoglobinuria, caused by the heme pigment nephropathy from free hemoglobin. They block and also cause active inflammation, may require hemodialysis in severe cases, and mostly the preventive intervention that we can do is adequate or optimal hydration. In terms of morbidity and mortality, up to 11% cases there can be mortality. Mixed variety is difficult to treat with a poor outcome, with the mortality can be as disease recurrence can be 4 to 43%. Increased mortality also present in severe transfusion dependent and refractory cases. Risk of chronic disease occurs with recurrent relapse, specifically in secondary autoimmune hemolytic anemia with underlying hematological malignancy or autoimmune disease. Treatment related complications like long term immunosuppression will be a challenge to manage. Diagnosis, standard routine blood test like CBC for anemia, normocytic or macrocytic RBC will be there due to reticulocytosis. Normal WBC is a platelet count unless there is an underlying bone marrow suppressive disorder. Reti count is usually elevated up to 15%. It reflects bone marrow compensation for the hemolysis. It may be inappropriately low if there is a bone marrow dysfunction. Maybe because if these autoimmune hemolytic anemia associated with some hematological malignancy involving bone marrow. If you look at the blood smear, in case of warm variety, there will be spherocytes and microspherocytes. In cold variety, there will be RBC agglutinin and minimum spherocytes. In paroxysmal cloned hemoglobinuria, there will be spherocytes and erythrophagocytosis. There will be positive hemolysis markers like high LDH, specifically in intravascular variety. Haptoglobulin will be lower absent. It's a very sensitive marker. Bilirubin will be elevated. And mostly it is unconjugated and typically 2 to 3 milligram per day. It can go up to 6. But this kind of jaundice caused by hemolysis is unlikely to cause higher bilirubin than 6. And free hemoglobin in serum and urine can severe cases. Additional tests like that need to be done, cold agglutinin titer and Donat-Lens Steiner test in certain groups. Now, if you look at the direct agglutinin antiglobulin test or agglutinin test, this is a cornerstone diagnostic check with a sensitivity up to 99%. That strength correlates with hemolysis severity. That negative autoimmune hemolytic anemia can be 15%. We discussed how to handle them, and enhanced testing method may need for those patients. In terms of treatment for warm variety, first line is corticosteroid, prednisolone 1 to 2 milligram per kg per day. Need to be tapered after 14 to 21 days if the patient is responsive. In severe cases, we may consider to add rituximab. There are RCTs showing improved outcome. Treatment need to be continued for at least 3 months after complete remission. If the first line fails, we can consider for rituximab for sure, with a response rate up to 70 to 80%, with a median duration more than a year. Splenectomy can be considered, but response is around 60 to 70%, but this is not a common practice at this moment. Can consider other immunosuppressive drugs like azathioprine, cyclosporine, and mycophenolate mofetil. There are adjuvant therapies for refractory cases like bortezomib, complement inhibitors like eculizumab or FcRn inhibitors, low-dose cyclophosphamide or continuous low-dose prednisolone, danazole in elderly population, and hematopoietic stem cell transplant in severe cases. Now, the treatment is mostly the domain of the hematologist, and intensivists will collaborate with them to ensure the appropriate therapy that the patient can tolerate. But the emergency management will be our domain, where we need to transfuse the patient, the hemoglobin is less than 6, or even if there's hemodynamic compromise, we may need to transfuse at the higher hemoglobin. Use least incompatible units. Do not delay transfusion with the risk of because of fear of hemolysis. IVIG can be considered in severe cases 1 to 2 gram per kg. Plasma exchange is an option, and VT prophylaxis you should not forget. In terms of cold agglutinin disease, avoidance of the cold exposure with warm clothing of the acral area, gloves, scarves, yarn muffins important. Warm living environment, avoid cold food beverage, use blood warmer in all transfusions. It's a critical requirement. And you can give some B-cell directed therapies like rituximab or bendamustine is the recommended first-line therapy with a response up to 80% and durable response, more than 88 months in some cases. There can be considered for rituximab monotherapy, response rate is a little less, nearly 60%, or rituximab plus fludarabine is an alternative option, but usually have a higher toxicity. We can consider different complement inhibitors. Among these, sutimlimab is an option by FDA in 2022. And it's a humanized monoclonal antibody targeting complement C1s, rapidly halt hemolysis within 1 to 2 weeks. Indication is Reduce transfusion need and hemolysis in adult with CAD, cold variety, and require continuous treatment. Hemolysis return after discontinuation. That's a big concern. Other options for refractory disease like bortezomib, ibrutinib, daratumumab, and emergency interventions like plasmapheresis or eculizumab. There are other small differences in treatment, like in mixed variety, where you need to treat both, but we need to remember that splenectomy is ineffective and not advisable in this group, similar to cold agglutination. Splenectomy can be considered only in warm agglutination test. In that negative, we should treat them as a warm variety if you don't have detailed workup facility and a trial of what? A trial of corticosteroid is recommended. For drug-induced, again, treatment is as a warm variety, but we need to stop the drug and no drug repeat exposure should be considered. There are some more important points like all patients with active hemolysis should receive folic acid supplement. VT prophylaxis I'm repeatedly mentioning in refractory cases, we need to send them to a specialized center and the secondary cause need to be evaluated and treated concurrently. So if there's autoimmune disease, same stenoid may help. If there's hematological malignancy, we probably have to start some chemotherapy to get a response. For paroxysmal cold hemoglobinuria, often supplementing hydration to prevent acute kidney injury. Glucocorticoid has a limited efficacy but can be considered in severe cases. In refractory cases, rituximab, plasmapheresis, complement inhibitors like eculizumab, splenectomy is not effective. For passenger lymphocyte syndrome, mostly self-limiting, 1 to 3 weeks, resolve as the donor lymphocytes are eliminated. Transfusion strategy is important. Use donor blood type RBC, O type if needed, and adjustment of the immunosuppression regimen may be needed. For severe hemolysis. Again, supportive care like IVIG, plasmapheresis, and rituximab. Red cell antigen genotyping may be helpful in complex cases. In terms of recent advances, there are some new molecules are in the market. Like in terms of complement inhibitors, I already mentioned sutimlimab, which is an anti-C1s antibody. So FDA approved and target classical complement pathway of complement C1s level. Other complement inhibitors like eculizumab, pegcetacoplan, which is an anti-C3, and rilpirubat, which is anti-C1s. These are new generation molecule, and you can also consider FcRn receptor blocker, which blocks neonatal FC receptor to prevent IgG recycling, reduce circulating pathogenic IgG autoantibody by increasing catabolism. Candidate for in development like Evgariti, Gmod, and others. Very difficult to pronounce, honestly, an intensivist. There are other additional emergency approaches, already like proteasome inhibitors, BTK inhibitors like ibrutinib, anti-CD338 like daratumumab, BL2 inhibitors, low-dose interleukin-2 inhibitors, and JAK-STAT inhibitors. Future direction, it may be helpful if you can develop a biomarker-driven precision therapy, combinational therapy for targeting multiple pathways, and long-term follow-up in these patients to assess or diagnose early remission. So key prognostic factors, autoimmune hemolytic anemia subtype, as I mentioned, mixed variety has a poor prognosis. Initial presentation, severity, hemoglobin less than 6, evidence of hemodynamic compromise, usually have a poor prognosis. Elderly people do poorly, specifically if it is more than 60. Underlying lymphoproliferative disorder and active autoimmune disease usually have a poor prognosis, and along with complications like venous thromboembolism and acute kidney injury. Response to therapy and the risk of recurrence, the refractory disease are also a poor marker. In terms of long-term consideration, most autoimmune hemolytic anemia causes long-term monitoring, 50% relapses. In case of secondary autoimmune hemolytic anemia, prognosis largely depend on the underlying condition outcome. So if you can manage the underlying autoimmune disease or hematological malignancy better, they usually do not recur. Otherwise, you need to continue treatment for them also. In terms of future generation, there are some new molecules that I've already mentioned, along with genetic profiling to identify susceptibility factor and personalized therapy in certain group of patients. So to summarize, autoimmune hemolytic anemia comprises different variety of disease with a different serological finding and thermal activity. So the treatment are different. Most common is the warm variety up to 80%, IgG mediated. Cold variety is IgM and complement mediated. Direct agglutinin test or PUM test is the cornerstone. It will be positive for IgG or complement 3 depending on the type. Key markers are anemia, reticulocytosis, elevated LDH and bilirubin, and low haptoglobulin. High risk of venous thromboembolism. Need to identify or the search for secondary causes which trigger this autoimmune hemolytic anemia. In terms of treatment, warm variety, corticosteroid and rituximab. Cold variety, avoid cold along with rituximab and bendamustine, complement inhibitors. Paroxysmal cold hemoglobinuria is also self-limiting. Sometimes you treat uh, with a supportive care and cold avoidance. Complement inhibitors can have some role in this subgroup of patients. By this, I'd like to conclude and thank you for your time. I'm sharing a barcode for your feedback. Feel free to scan it and give your feedback so that I can do better in my coming presentations. Thank you. See you in my next presentation.